Let's focus on acute kidney injury, specifically how the NCLEX will test your understanding of its causes and management. The exam loves to present a clinical scenario and ask you to identify the type of injury or the priority nursing action. We have three main categories of acute kidney injury. Prerenal injury is caused by decreased blood flow to the kidneys. Think of a patient with severe dehydration, hemorrhage, or heart failure. The kidneys themselves are not damaged yet, but they aren't getting the blood they need to function. Intrarenal injury is direct damage to the kidneys. This could be from nephrotoxic medications like gentamicin, IV contrast dye, or a condition like glomerulonephritis. Here, the problem is inside the kidney itself. Postrenal injury is an obstruction of urine outflow. Common examples are kidney stones, an enlarged prostate, or a blocked urinary catheter. The NCLEX expects you to differentiate these. For example, a question might describe a post-operative patient with hypotension and a urine output of 20 milliliters per hour. Your first thought should be prerenal injury due to potential hypovolemia. The priority action would be to restore perfusion, likely with an IV fluid bolus, not to give a diuretic, which would worsen the problem. That's a classic exam trap. Another key clue is the BUN to creatinine ratio. In prerenal injury, the ratio is often greater than 20:1 because the body is trying to conserve volume, leading to increased reabsorption of urea, but not creatinine. For intrarenal damage, the ratio is typically lower, around 10:1. Now let's discuss the phases. The oliguric phase is characterized by low urine output, fluid overload, and electrolyte imbalances. The most dangerous of these is hyperkalemia, which can cause life-threatening cardiac dysrhythmias. You must be able to recognize peaked T waves on an EKG as a sign of severe hyperkalemia. Nursing priorities here include fluid restriction, monitoring daily weights, which is the best indicator of fluid status, and implementing a kidney-friendly diet low in potassium, sodium, and phosphate. Following this is the diuretic phase, where urine output increases dramatically, sometimes several liters per day. The trap here is thinking the patient is cured. In reality, the kidneys can't concentrate urine yet, leading to a massive loss of fluid and electrolytes. The patient is at high risk for dehydration, hypovolemia, and hypokalemia. Your focus shifts from preventing fluid overload to preventing dehydration. Finally, the recovery phase can take months. A helpful mnemonic for remembering the indications for starting dialysis is A-E-I-O-U. A for acidosis that is severe and not responding to treatment. E for electrolyte problems, specifically severe hyperkalemia. I for intoxication or poisoning. O for overload of fluid that diuretics can't resolve. And U for uremia, when the patient develops symptoms like confusion or pericarditis. So when you see a question about a patient with AKI whose potassium is 7.0 and has EKG changes, your priority thought process should lead you toward preparing for emergency dialysis or administering urgent medical treatments like IV calcium gluconate to stabilize the heart.